All right, everyone. I'm Brendan Hodge, founder and CEO of Citizen Health, and this is our fourth episode of Rebuilding Healthcare with today's topic of global health systems. Now, I'm really excited about this one because I think this might be a world's first, where we have physicians representing the United States, Canada, the United Kingdom, India, and Singapore. And we're coming together to talk about the pros and cons of our country's healthcare systems. I don't think that's ever been done before on video in real time, so it's amazing. And before we really get into this, I just want to thank everybody for spending an hour of your Saturday with us. Time is valuable, so thank you. And also, I want to give a shout out to my co-founder and COO, Megan Janis, for putting this webinar together. Coordinating everyone from around the world is very difficult, and it worked out perfectly. So thank you, Megan. And let's just jump right into it. And since we do have a large group of people out here, I couldn't do it justice introducing everyone. So let's just go around the digital table here and let everybody introduce yourselves. Spend a couple minutes just telling everybody who you are, your background, to shed some context in this discussion. So, Dr. Amir, would you like to go? I guess we can go that way.
Okay, thank you. Well, I'm Dr. Amir Hanan. I'm a general practitioner, family physician based here in Manchester in the UK. I've been a general practitioner for the past 18 years now. I work in a smallish general practice looking after about 12,500 patients, providing primary care services for them within the National Health Service here in the UK. I have a number of other roles as well, including being the chairman of the World Health Innovation Summit, which is a global organization that operates in all 5 continents throughout the world.
Thank you. Dr. Jit?
Okay, hi everyone. I'm actually Dr. Tan. I'm from Singapore, and I'm a family physician here doing basically long-term home care for the disabled elderly. I'm involved in many technology, medtech companies as well in this part of the world. And I'm still a full-time doctor doing telegeriatric services, doing home care services, and running a family practice in the neighborhoods.
All right, thank you. Dr. Ernie?
Yeah, good morning. I'm Ernie Sussman. I'm a urologist in Las Vegas, Nevada, and I reached out to Brendan about 6 months ago, and we put together our first town hall just about my gripes and the inequities of the American healthcare system. It's really how the corporate greed has penetrated every aspect of our delivery and what we can do at multiple levels. We had a lot of good people attend that first online town hall. We continue to communicate. The other month we had a conference in Washington, D.C. called Free to Care, where we had some of the stars from previous webinars, Dr. Mast and David Balad and some other folks, Kim Corbett, just to name a few. It was an amazing turnout. Even Dr. Ben Carson was there, who is a famous pediatric neurosurgeon from Hopkins, who is now in the president's cabinet, who came to speak with us. And then the following day, we got to meet some members of Congress who are advocates and some of the physicians in Congress. So we've been just gaining momentum and gaining energy. And I think this is our fourth one. And I congratulate Brennan and Megan for continuing to put these together. And thank you, everybody, for joining this morning.
Thank you, Ernie. Dr. Alexander?
Good morning, everyone. I'm a physician from Canada, and I'm a family practice an emergency doc. I was very involved in all of the healthcare improvement initiatives in trying to computerize our system and improve how my colleagues were able to support patients. And I look forward to this discussion because there's much that we can learn from each other. And we can't just say we've made progress in healthcare, we need to persist. And my favorite quote is Margaret made, it's only a concerned group of citizens that can change the world.
I love it. I love it. That's one of my probably top 10 too. Dr. Ravi?
Yeah, hi. Thank you for this time, Brennan and the team here. My story is a little bit divided between two nations, two great nations. And I'm in USA right now, but I'm also from India, graduated there in 95, and I've moved to US in 97. So last 20 years, I've been here, but I've been in touch with the Indian health system. Basically, I'm here to have this discussion with you guys and see where we go. And if you want to know more about me, I mean, you can put in hashtag removing barriers to healing. So you will get my method to madness.
All right. Thank you, Dr. Ravi. And all right, so we have a great group of people here, and everybody that's out in the that's listening to this, feel free to chime in with your chats, ask questions, and we have a good dialogue going on the side here. And also the transcripts of these, the chat messages will be on we'll post a blog post about this. And we have a set of questions here about our country's healthcare system. But real quick, I want to share my screen with something that a chart that I found that ranks countries in orders of healthcare efficiency. So let me share this real fast, just so we can have some context of what we're talking about here. All right, so you should see this, the Bloomberg healthcare efficiency. Everybody sees that? Sorry, I got 4 screens in front of me. A lot of times I get confused.
Yes.
All right. So as you see here, there's plenty of charts out there that ranks countries. This one is, I like it because it's very just straightforward. And Dr. Tan, you see Singapore, you're up on there in the top 3, and that's amazing. I think there's probably going to be some part 2, 3, and 4 of this particular webinar. I'd love to talk more about individual countries, kind of take a deeper dive. I love what Singapore is doing. And of course, ranking number 2 here. And if we can just scroll on down to see where some of our other countries are at Canada, ranking number 16. And the UK is down here, 35th. I mean, you're spending $4,300 per year per citizens per capita. And this is the average life expectancy, 81 years. And you keep going on down to, I think, did I pass up Canada? Did I? Yeah, Canada. I'm sorry. I was back here, 16th, $4,500 per citizen, good life expectancy. And you get all the way down here. India is further down here. I miss India. Basically, the U.S. is absolutely terrible. And if you start looking at this is the relative cost, and this is the absolute cost. That's crazy. And a lot of people have seen that. And just general stats is America spends about 2.5 times more per person to have a lower life expectancy than most of the developed world. And there's plenty of charts you can see that showcase how ugly that is. But that's not necessarily the topic of today, to talk about how bad it is. We really want to talk about what is working in our healthcare systems and what can be maybe shared across healthcare systems, across countries. What are really the highlights of your particular country's healthcare system? That's our first question. I'd like to jump right into that. What is the best parts of your country's healthcare system, and what makes the most sense, and why do these things work well? And Dr. Mir, I would love to start with you because I'm fascinated with the NHS, and I know you've done a lot of good work in there, and I'd love to hear your views on what's working there at NHS.
Okay, well, what are the best parts of the country's healthcare system? Well, the first is the NHS itself, by a huge margin. I feel very proud working in the NHS. Why the NHS? I'm going to start with the Constitution that you may not have heard of. The Constitution starts with the NHS belongs to the people. It doesn't belong to business people. It doesn't belong to the politicians. It doesn't belong to the doctors, nurses, or anybody else. It's to the people themselves. It's there to improve our health and well-being, supporting us to keep mentally and physically well, to get better when we're ill, and when we cannot fully recover, to stay as well as we can to the end of our lives. It's a national treasure, as I've described. It's not aimed at making a profit, but delivering care funded through a tax-based system so that all who work contribute towards it, ensuring that everybody gets the benefit. It's free at the point of care for all, regardless of color, creed, status, political affiliation, the ability to pay, sexuality, or need. Acute care is available ever to all. But the jewel in the crown, I believe, is the primary care and the fact that it's based around not just the patient, but around the family. And it's this relationship that I, as a GP, have with the family that's so critical to its success. The GP practices have all got fully functioning IT systems in place, and that helps us to deliver the great care to patients and families. And to give you some idea, as a GP, I've had an IT system for the last 19 years now, so it's highly developed to support the work that we're doing, particularly around chronic disease management. And as small communities slowly disappear, the GP practice is often seen as a very important trusted place that people can go to, where a lot of other things have disappeared.
I know there's a lot of comparison. Well, I'm not going to say comparison between the NHS and what we have. We have media that portrays the NHS in a different way than I think it actually is. And this is why I'm so excited about this discussion, is because we actually get to hear it from you guys, and versus a spin that we could hear on Fox or CNN. So I like that point that you made, that it belongs to the people. And I think you have to have a stake in this system to really make it work. And having that context, it's a completely different mindset than what we have over here. I mean, I don't want to get into the problems. Matter of fact, Dr. Ernie, you could actually shed some light into, why don't we do that, Dr. Ernie? Could you shed some light into kind of where we're at in our financing and how we pay for healthcare? Yeah, I would like to do that. Since we're on the NHS topic, kind of compare how we pay for healthcare versus how the NHS pays for healthcare.
Sure. Let me bring a screen over. Hold on.
Yeah, that's I like this direction. And this is a freestyle. We got some topics, but whatever you want to talk about, just bring it up and we can discuss it. So we got try to keep it at an hour.
Hold on.
Everyone's time.
When are you guys talking for a minute or two? Let me try and bring over my slide.
Sure. Yeah, no problem. So I'll tell you what, let's just hop over. Let's just stay on that topic. So Singapore, now this is interesting here. Like we could spend some time on this. Dr. Tan, can you explain how healthcare is paid for in your country?
Well, it's like the marriage between your NHS and the insurance system. So we have in Singapore for primary health, about % delivered by the private GPs, 20% is by the public sector that we can talk about. And for also specialization, it's the opposite. 80% goes to public hospitals, and 20% insurance goes to the hospital. So how we pay essentially firstly out, and then we have enforced or mandate. It's part of our central purchase fund, CC, and that is paid. And thirdly, Medicare is a program. It is also mandatory, and this helps us offset some of the.
Enter your participant ID followed by pound.
And lastly, we have basically insurance systems that actually let us claim insurance and pay out for whichever services that we are getting. And lastly, we have a Medifund. And Medifund is for what we call public assistance cases, whereby everything else is paid for by the government. So we have so-called 5 ways and how people in Singapore pays for it. And as I was saying about the primary healthcare is basically private GPs, and they are very, very accessible. It's totally walk-in, and you get to see the GPs anytime. And of course, if for 24 hours, we have a private 24 hours clinic, or we have the emergency department in the hospital, which are 24 hours. And Singapore is a very, very small space, small area. So everything is rather efficient. You know, I give a call to whichever service, ambulance service, they'll be here within 7 to 10 minutes. And within the next 5 to 7 minutes, you are in the hospital, you see. So everything runs like a clockwork here. And of course, we still have a difficulty nowadays because of our aging population, and we are looking to essentially increase some of our ILTC or intermediate and long-term care processes and funding. Other than that, I mean, the primary health care and the tertiary care works really efficiently around with various sources of funding from the government, from self-payment, and from the insurers.
Brennan, unmute yourself. Brennan, unmute yourself.
That works. Thank you. Thanks for the reminder. Yeah, everybody said there's echo or some interference.
Yeah, you just have to mute the speakers, the other people apart from the speaker. I think that should be the best way.
Yeah, that works. All right. Well, yeah, I was asking about the population in Singapore. I was curious. It's about 6 million. I was curious what that was. Interesting.
I have a question for Dr. Tan. That with the aging population, how are they cared for? Are there strong family units? Do they go to assisted living? Do they have assisted living either at the home, or are there assisted living senior centers where they go and live, and they have like their own living facility apartments with help there to take care of their needs? Is there a breakdown, or how does that work out there?
Okay, so that's a great question, and that's something that I can answer you because I'm one of the leaders in these sectors. So what happens is we have a few ways that we care for our dependent older adults in Singapore. So firstly is we have nursing care facilities that we have been building up, and that is subsidized by the government. But that takes in what we will be planning for, maybe 10 to 20% of the population. And the rest, we have this called foreign domestic worker services. So in Singapore, we are very small, but we are much richer than the rest of the Southeast Asia. And we do have this manpower law that we can appoint caregivers from overseas. So I can, like if my patient is staying at home, he's ADL dependent, I could hire a caregiver for her, or one or even two caregivers for her, and she'll be taken care at home 24/7. The other way is we can get her into a nursing care facility, and that will be similar to, you know, other places like America or Canada. But we do have this flexibility, and this is the option that most of the people will get: employ foreign domestic worker as carers. And we are actually training these foreign domestic workers in their host country, and they are coming in as trained supporting so-called allied health personnel. They may not be nurses standard, but they are really good at doing, you know, transferring, changing of diapers, feeding the patient, you know, those caregiving work. So that is usually how we do it in Singapore.
Thank you.
How about Canada? Alexander, you want to talk about the single payer system in Canada and how, I guess that's our biggest, as far as America, our biggest comparison. And also, you know, with the media, people talk bad about Canada, and you hear both sides of the story, the good and the bad. Could you shed some light on that, on the good and the bad?
Yeah, and again, this is different than an official policy position, because for those, you can go online and read the websites. And in fact, for my tech company, I've recently had to travel to, you know, World Economic Forum's Asia meetings to Sweden, to the UK, and presented the NHS and a lot through the US. I was just at Capitol Hill presenting at one of the HHS commissions. And number one big myth that we have to undo is that there's a healthcare system out there, because everyone says, oh, you know, Canada at least is one system, or the NHS is one system, or Sweden is one system, and they're not. Having talked to actual people on the ground who are clinicians or decision makers, Canada is divided. It has a single payer nationally that collects the taxes of everyone and then redistributes the money. But then it gets redistributed to each of the provinces, and there's 12 of them. And each one of them then further redistributes it into different pockets, and different people get paid differently. And so it all amounts to a publicly funded insurance scheme, but it's certainly not unified. And having talked to folks in the NHS, they have 259 buying authorities. You know, Sweden has 8 regions. And so we have this big sort of an idea that someone else has it easier or better because they're more simplified. And that certainly hasn't been the experience of what I've seen. Each one of our provinces are huge. Just to give you a sense of a size, the entire population of Canada is equivalent to, let's say, the city of Shanghai or the state of California, so 34 million people. And all of these comparisons always make me laugh, especially the OECD ones, because we're the only ones where geography and weather combine, right? And so 34 million people living across the kind of geography where it's brutally cold half of the year, and you have to staff up hospitals where they may be an hour apart on the map, but there's a huge mountain in the middle, or, you know, 6 months of the year, you cannot easily drive from one to the other. So you're going to have duplicate emergency rooms and hospitals to provide service to the population that lives in those 2 locations. And they're not going to be super efficient, but that's what it takes to have people live in those places. And so 90% of our population is an hour drive from the border to the US. And we have pockets of population up north that need to be serviced, and their needs are vastly different. The size of British Columbia, just one of the provinces where I live, is about the size of Germany and England put together, or California. And then people say, oh, you know, Holland doesn't have a telehealth service that's really well developed. Do we need it for Canada? And you're like, yes, we do, because of the distance. And so if 30% of the visits don't require a physical exam, why are we making people travel? And yet, you know, I was one of the chief medical officer for the first direct-to-patient telehealth service. And we invented that, you know, 8 years ago, and it's still a tiny little proportion of the visits happen through telehealth. I think we have like 50,000 patients who've taken advantage of that across the country. And so, you know, I wanted to start sort of with a comparison of perspective, but on the good news side is, you know, we have a family practice, vibrant, dynamic, committed group of physicians. They're fighting hard to make that into the backbone of the healthcare system, but about 30% of patients in big cities don't have a regular GP, not because they don't want to, they're just not enough. And most GPs who practice full practice are disappearing. The younger graduates are saying, this is crazy, you expect me to do what for patients on what hours? And they are being pulled into secondary needs, such as cover emergency shifts, hospitalized patients, deliver sports medicine, palliative care, and other things. And so they typically split their practice between being a GP and doing some of these activities. And so the walk-in clinics are thriving, and that type of episodic care people think is for the worried well, and that's what our headlines would say. I still practice, and I sometimes cover shifts in a walk-in clinic, and you would see patients who survived cancer, who have diabetes, high blood pressure, and have a new onset sort of an accident requiring multiple providers, you know, scare of a stroke, or they fell, and they end up in a walk-in clinic without being doctored. And so if you have a big problem, our healthcare system is amazing. If you had a heart attack, or you had big healthcare condition for which medication is really expensive, cancers, we're the best in British Columbia for the world outcomes in terms of cancer treatments. But if you happen to be one of those unpopular diseases like mental health, you will wait 9.5 months to see a psychiatrist for the first time. You will not get your psychology help counsel. I had a patient pretend to have a suicide attempt in order for them to get faster. And so, this is the reality from the ground, which is not as fabulous. And having talked to people everywhere I go and give a talk, I say, have you guys figured it out? Can we just kind of take what you've done and copy it over to our system? And the answer is, oh no, we've made progress, we're doing this. But it's certainly not a model that we would recommend exporting.
So that's surprising. So the general practitioners are decreasing in numbers in Canada. Is that what you mentioned? I guess.
Well, the number is actually sort of relatively stable, but population is increasing. So the number of GPs per population is going down. How many hours they work is also changing. And there was a big study that blamed women for that. And most of the women got very angry at it because they said the reason why people can't find GPs is because all of these mothers who are taking maternity leave or working less hours. And the actual study showed that a usual GP works 56 hours a week. If you have 2 children under the age of 6, you work 6 hours less. And that's still 50 hours a week, which is way more than the general population. But the headline from our own medical association sort of and the newspapers was trend shows feminization of medicine results in less access for patients. And everyone's trying really hard, but the gap between pay for specialists and GPs is getting worse. And so GPs make good amounts of money, but the average reimbursement per visit, because most of us are fee-for-service, hasn't changed that much. So when I started practicing 18 years ago, you got paid $29.99 per visit, and it didn't matter really what that visit was. And if someone was really old, you got $10 more, but you know how many more problems they had, and so that was relatively not worth it. And so I think that now the fee is $35, and I still have to pay for my rent and my assistance and all my equipment and my increasing college fees and other things. And so, we practice because we think it's important and people figure out ways of making it work. But if you look at the percentage of doctors' children going into medicine, it's decreased dramatically, and the burnout rates are 58%.
Wow, it's very similar to what America is going through right now. And especially with the gap between primary care and specialist. And there's a lot of factors into that. A lot of it is your medical school loans. They're just escalating so much. You're up to $250,000 of a graduate has. Of course, they're going to go to a higher paying specialist position so they can pay that back. And you just have that gap now. And I'm curious too here, what is the average face time that a GP has with a patient in Canada? Like just direct interaction.
Well, so if you actually look at the higher billing family physicians, the average face interaction is lower. They've implemented this 1 complaint per visit rule. So if someone wants to talk about a second visit, they're going to have to show up the next day. And I have colleagues who practice in the same clinic that totally demoralize the rest of us because they show up at 8 and by 11 o'clock they've seen 40 patients and they go home. And all of those patients leave very satisfied because they've gotten a prescription for medication or a test of some kind they probably didn't need. And so I can't see 40 patients in a day. That's ridiculous because I just can't practice at that pace. And I don't feel like telling patients no for one reason a visit, because typically reason number 4 is the one that's big and scary and they didn't want to talk about. And so I end up spending 10, 15 minutes per patient, sometimes even longer, persuading them that they don't need that additional CT scan for headaches, but they actually need to start sleeping. And if they sleep well for 2 weeks and the headaches go away, then problem solved. And so this whole relationship building discussion that we need to have is not covered. And so all of us have found ways of fitting it in within our practice style, getting the clinic to accept that just because we're not the highest billing doctor on their roster, they should keep us. Because some clinics, also need to make the ends meet, and they remove doctors who are not as efficient per hour. make it sense. And so I've started asking questions to people when they show up for a visit. Let's say heartburn. I said, do you want me to explain how to modify things and change lifestyle and so that you don't experience heartburn anymore? Or do you just want the prescription for the anti-acid medication? And 50% of the time, honestly, patients say, just give me the prescription, doc. I'm super stressed. I have no time to change things. And you're like, great. So that visit was 3 minutes. And I said, when you're ready to talk about lifestyle modification, please come back. And it's amazing because most of them come back within the year and they say, we appreciate the fact that you understood that I was under so much stress and you solved my problem, but I don't want to be on medication for the rest of my life. And so that has helped me do this. It gives me great satisfaction to help people well in a visit. And that's how, that's what fuels me as a person. But if my motivation wasn't that strong, because I was a patient when I was a kid and I remember doctors taking the extra time, I would have been one of those statistical burnt out doctors too.
So there's a movement going on here in America and a couple other countries called direct primary care. Are you familiar with that?
No.
It's like a subscription to a primary care physician, kind of like a gym membership. I think the average is about $75 a month, and you pay them and you can see them as many times as you want to, virtually unlimited. Call, text, email, and it's not just one issue per visit. It's sit down for 45 minutes and get to the root cause of your problems. And it's relatively new. It's been going on past 10 years, growing on. It's escalating quickly, and people love it. The patients are loving it. The physicians are loving it. Now employers are getting in loving it because you're really helping the patient. It's not that reactive care model where you give them a prescription and 3 minutes are out the door. You actually spend some time figuring out their problems and you help them. You help them get better sleep, to lower their blood pressure, to go exercise and eat better. And that's a model that I'm really curious to see how that will play out in other healthcare systems, because here in America, it's definitely working and it's actually saving people money. We spend way too much. It saves all those entities money, and actually physicians are making a little bit more doing this. So I'm curious if
we have a concierge medicine model that we've heard Americans do. Usually the fee is about like $1,000 a year. And so there are a few executive physical clinics that are available at about that range. So it's $1,000 for you as a person, and another $1,000 throws in the family as well. And I mean, capitation has been tried, and we can have a long discussion about that as well. But I mean, we need to start changing these things, and the way our fee-for-service systems work are locked in within governments. I was working with the Medical Association to try and change some of those things. And we got some funding to implement electronic medical records and different fees for more complex patients. But they're doing the same thing as Medicare. Is they're selecting a few diseases and saying, if you're the lucky one to have a stroke or heart attack or whatever, then yes, your doctor is going to get paid more. And you're like, what about complex patients who don't fit into that little box you've just created? And that's a problem. And Dr. Amir, you mentioned using your EMR for population health. I wish. Most of our EMRs are just glorified documentation of clinical visits and billing machines. They theoretically have the tool to do population health, but it takes someone who is either obsessive compulsive in terms of clicking little boxes, or who is particularly determined and has 3 days to get a single question answered in order for us to be able to use it. And so we have computers that were supposed to make our lives better, but they didn't. And all the studies that I've read show that the US suffers the same. I've never met a physician who loved their EMR. And so if you love your EMR, you're the first.
Well, if I can jump in there, definitely the clinical systems that we're using really helps us. But it's not just the clinical system, and you made a good point there. Our payment system is based on us providing good quality chronic disease management for the individual, I should say. So, for instance, hand on heart, I can tell you that if you're a patient with diabetes, if you're a patient with heart disease or chronic obstructive pulmonary disease, or even, dare I say, depression, there is a standard of care that you will get that is in line with the evidence-based medicine. I'm not going to say it's the best, but it's in line with the evidence-based medicine. And what that means is that if you've got heart disease or diabetes or hypertension, then we will manage your blood pressure and get it down to adequate control. You will make sure that we do everything we can to help you to stop smoking. And we will give you advice on lifestyle changes in the way that you've described. And that's part of our payment-based system and our quality, which is great. But just taking things a little bit further beyond that, and maybe some of the challenges, we also know that things like diabetes and hypertension have a big personal component attached to them, your own lifestyle choices that you make. And clearly the NHS and your GP or your doctor can't dictate to you how you live your life and what choices you make. And one of the challenges that we are facing in the NHS in healthcare is that as people are living longer in the way that Dr. Tan, you described, we're beginning to realize the edges of what we can do in healthcare and how much more important it is to think about the home, the family, the carers, and supporting them in terms of continuing to live life. And we're starting to think about how healthcare services can work in conjunction with communities and co-produce care rather than us trying to do it to them.
Can you elaborate a little bit on that, on co-produced care with the communities? Because that's a big thing that I've been thinking about, because we have a lot of organizations that we could leverage.
Okay, so if you think about the culture of organizations, the major factor that determines the culture of an organization is the board itself. And so it's really important to see who the board members are. And we know from other work from around the world, not necessarily in healthcare, that those organizations that have a board that reflects the people on the front line and the people that you serve, they are more likely to make decisions that impact on the overall success of the organization itself and what it's trying to achieve. So you need to become very interested in who the board members are. If the board members represent the front line and those they serve, they're more likely to succeed. Now, one of the problems we've got in the NHS is it's the term the snowy white peaks, that the boards are not representative of the staff and the patients they serve. I was very fortunate to be sat on the Equality Diversity Council for NHS England. And one of the things that we did during my term was to enable people with lived experience to sit on that board. What I mean by lived experience is take the people that are the most disadvantaged in society. So they could be refugees and asylum seekers. They could be people that have spent half their life in prison. They could be people who've suffered with alcohol and drug problems or been homeless. And these are the people who often enjoy the worst outcomes in society. Actually, if you try and support them and put them onto the board, then you can then start to begin to understand how an organization will start to change in the way it makes its decisions that don't just impact on those who speak well, like us, if you like, but also those who are most disadvantaged. That's what I'm talking about. I presented at the NHS Confed last year on the requirement to do this and start to think about non-exec directors that actually hold boards to account to enable this to happen. It's a journey that we're going on, but we're beginning to realize that there's no more money in the system. We have to make do with what we have. And actually these decisions about who makes them and who they represent is as important as the amount of money you have.
I completely agree.
And then on the ground, it's about supporting activities that are happening in the community. So, for instance, we have something called Park Run, which is in the community. It's a free, voluntary-led organization. GP practices are being signed up for it so that they encourage staff and patients to go for a run every Saturday morning at 9 o'clock. We're doing small activities. So, for instance, for our patients with Parkinson's disease who might suffer with loneliness, to come along and do tea parties where they organize themselves, but it's done within the GP practice or within the local community. And we encourage people to go there because actually by connecting people together, they're going to get better outcomes. They're going to spend less time in healthcare services themselves.
Interesting. I like that model. That's something that here in America we need to we need to think a little more about, because there's a lot of communities out there that are all fragmented that can come together and actually help communities in terms of health. It's a progress. Yeah, it's a process.
Brennan, just to add a little bit to what was just said, is I was in Washington on April 26th presenting at the Person-Centered Care Committee Day for Alzheimer's patients, and that was the conversation I heard, which gave me huge hope. It was that recognition that what happens between medical visits actually matters. And so I see there as the hope. We build a technology platform to move in that direction, and we're talking to different decision makers. And it's shocking to see that some people don't understand that who the disease happens to actually matters. And they're just thinking about the medical condition that they're in charge of. And so the primary care mindset needs to become dominant in conversations. And we need to start investing in community the way we know we should, instead of paying for more tertiary care.
I have a question to Dr. Greenville. And does the government not help at all with your medical education? And to follow up in your practice, you would think with the paltry reimbursement that they would contribute to your overhead, to your rent, and to your expenses. I don't know how they can expect to pay you so little and have you cover your overhead.
Well, they get away with it because a lot of us don't want to move somewhere else. I mean, our education is not as expensive as in the US, but the graduating rates of debt are around 150,000. And they've actually shifted who applies to medical school. So we've seen only the rich can sort of get in and apply. Plus, you need like a 99.9 average nowadays to get in. So it's hard to achieve that when you come from a disadvantaged background. And then once you're in practice, you get paid your fee. I mean, that's, it's a fee-based insurance scheme, and that's the extent to which we're helped. And so people who are very efficient make more money. The overhead is about 30% of what you would see quoted as our gross salary or more. And that's just the office overhead. And so I think I paid $16,000 for the privilege of practicing in all of my college and other subscriptions before I even see a single patient.
So 30% of your practice overhead is basically spent on trying to get paid? Is that?
Yes.
That's great. Yeah, it's about, over here, I've seen 3 different studies, anywhere from 42% to 68% of an average practice's overhead is spent just on trying to get paid. And that's a lot. You just might as well say half.
Well, I would say we have a single source of payment pretty much, which means that's the delta. You're paying 30% for the effort to figure out who pays, and probably 30% to the actual cost of running a practice.
Yeah. Wow. Okay, well, Dr. Ernie, how about, well, I'll tell you what, Dr. Ravi, can you shed some light on India? And Dr. Ernie, I'm going to get you to follow up to kind of sum up everything that we've talked about, all these different healthcare systems, and contrast that with America and how we're not doing things well.
So basically, as a bias, I want you guys to know that I've been in US since 30 years, and my interaction with the Indian healthcare system is my visits there and problems, and also I tried to set up some home care centers and really failed at it. But in a big picture, I want you to understand the realities on the ground. Say the population of India is $1.37 billion. And 1.37 billion people. And basically what the amount of food, money that is spent is on the GDP rate is only 1.15. And recently the government has increased the GDP funding possibly to 2.5. They have come up with this a scheme of insurance called Ayushman Bharat, which kind of insures like 5 million poor people, and that covers, like, give them 5 lakh rupees for secondary and tertiary care, only 5 lakh rupees for secondary and tertiary care. So nothing done for prevention, but at least that's a good start. And then The other thing is they are talking about using funds for something called a Swachh Bharat, which is like a clean India. It means that they use it for preventing the bathrooms and all this open defecation and all that. But coming to the part where things are really an issue is the reality of it. The reality is India is huge. The population is poor, is rural, uninsured, and also they are very, very, very price conscious. And there is severe shortage of doctors. I mean, people like me who get trained in the medical system there, I mean, we come off for the greener pastures, though I gave myself a life goal to create a healthcare system in India, and I'm starting to work on that aspect, hopefully going to give back. But what I'm trying to say is that there is a huge opportunity in India. The healthcare industry in India is a wide open industry in that you have an opportunity for impact investing. And also there is an opportunity for not just leapfrogging there, in pole vaulting. Like how can you do that? By thinking about it in a different manner, like creating, I've been conceptualizing this with understanding of creating something like public reporting in healthcare and creating a universal EMR, wherein the universal EMR is a thing that is very much valuable, like like Brennan was saying about creating a global EMR. I think that's what I see a huge value in. And we have, it should not be like just for billing purposes, but it has to be really for a real solution or attitude. And also the model has to have a national insurance program, a telehealth model has to be included, and also the mobile technology. And like I said, there's a huge opportunity to use people, process, and technology to improve the outcomes and help with the whole system. Brendan, you have to unmute yourself.
Sorry about that. Thanks for sharing. I'm curious about the nutrition side. I know you're big into nutrition. We have nutrition issues all around the world, especially in America, is absolutely terrible. How is it looking in India? Because I've been seeing some studies come out that's not promising in India.
Nutrition is a huge problem anywhere, you see. I mean, like there is a program that is being launched by Indian government for nutritional improvement, and that is slowly being implemented there. But come about it, for me, it is about 5 things really. In healthcare, there are really 5 problems. Suppose if we take cost out of the picture, suppose if we can talk it about a magic wand thinking, you know, like heaven and earth kind of thing, and magic. If I create a magic wand and take out cost out of the factor, if we have a real thing is personalization. Sorry, it is the 5 things that is communication is the first one. Communication, personalization, and basically thinking about how to implementation and realization and reevaluation. All these 5 things have to be kind of gotten into any assessment of outcome. Suppose if somebody is obese, they don't know that the real problem that is the nutrition. So without realizing the underlying cause of healthcare, we cannot go about trying to fix healthcare. So for any problem, we need to understand the real underlying cause. When we are going after this cost factoring, we are going after trying to cut down the cost of the thing. But if we don't understand the real cause, which nutrition is, I think that is what we have to go after. This is the global health fix.
Completely agree.
Can I share a story with you from this week? And that is that I received a letter for a patient of mine who'd just been diagnosed with a cancer. And because in the UK, patients are registered with a GP practice, although it was a specialist who had diagnosed him with the condition, they sent a letter to me. And we have this very beautiful relationship with the patient, which is a long-term relationship from cradle to grave. And it's not just the GP, but it's the practice nurse as well, and all our teams. Anyway, so I rang the patient up and just wanted to offer him my support. And he was taken aback completely and was really pleased that I'd rang him up and said, "Oh, Dr. Hannon, have you heard the news?" And I said, "Yes, that's why I'm ringing, to provide you with support so that if you need any further help, you know I'm right there behind you, supporting them," and so on. Which was an incredible support for him and his family, and he really appreciated that phone call at that moment in time. We talked earlier about we've seen that healthcare systems generally are very focused on the acute care, but don't think about the long term and what happens after the acute care. And it's a really important part of supporting patients. But if I continue further beyond that, what I think is the fundamental basis of healthcare, it's not really the hospitals or the GP surgery or the institution, but it's that basic relationship that a clinician enjoys with a patient. And Alexandra, you described that beautifully even in an urgent care center, where a person comes along and they're a great deal of stress, and you give them the option of saying, I can give you a medicine now, or I can give you a much more holistic approach, but that's going to take more time, and you're offering that to them so that they can come back to you again. And I think what we now need to do is we need to move away from this very item-based service where I'm here just to fix you or to give you a tablet or whatever it is, and start to value that long-term relationship, that continuity of care, and this, what I describe, a partnership of trust that exists between a patient and a clinician. It's the reason why the public trusts their doctors, at least here in the UK, and their nurses, and I should add nurses as well in that, more than any other group in society, because of that fundamental relationship that we have between our patients. Now, we're going to lose that if we start to chase after money and go after power and other things. But if we can go back to that fundamental basis and start to think about how we can build that right across the globe, that'd be wonderful. That'd be a very, very exciting place to be.
Well, if I can also add to what was just said is, to me, it goes back to the World Health Organization's definition. It's not just the absence of disease, but it's the presence of well-being. And it's understanding the impact that, most people are stressed because of work. So shouldn't we be fixing workplaces and how employers treat them? And if employers were serious about reducing their premiums, wouldn't they sort of emphasize all of the things we know that need to be in place in order to have workplace wellness? And for the women angle, it's not just a daycare on site, because that would help people who have one kid who is under the age of school age, and we need to have flexibility so that the sandwich generation can run home early or arrive late or leave in the middle of the day or take phone calls because they're managing aging parents and younger kids and school-age kids who have anxiety about tests. And so is that sort of a workplace wellness? It's connections. I read with great surprise that the US Surgeon General, who retired after the last administration, said that his biggest area of interest and focus is loneliness and curing that. And he produced a number of statistics showing that if an elderly person who's perfectly healthy stops having connections, they die within 10 months. And so, we need to start thinking about all of these factors that are not on our radar. And I did this quick sort of my plea to the world was a TEDx that I did about how a vision for success is Star Trek and having these devices that sort of diagnose everything instantly. And I grew up with that idea as a kid and went into medicine, and then I realized that none of these devices capture half of what actually matters. And half that matters is the personal experience that a patient has had, their fears, their concerns, their hopes. And we will always need a human to step in and partner, because when you're faced with some of those big decisions and you feel all alone, you need to have someone to help you interpret some of this data and make sense of it. And I love patient-oriented evidence that matters, poems. So it's not just like how is your blood pressure doing, but what kind of an impact will that have down on the road? And so this conversation gives me hope that there are people on other countries and continents who are worried about the same things.
If I may say so, then I introduce myself as saying I'm the chair of the World Health Innovation Summit. If I just share a little bit about that, it just follows on with what you've just said, because we're taking a very person-centered health preventative approach rather than a disease illness approach, and it's approach to health and well-being. And we've got 4 pillars in that, which is the economy, which is about jobs, education, the environment we're in, and building ecosystems. And what we're trying to, and these are really our values, is help people to become more aware and educated about each of these pillars that impact and how they impact on their daily lives. So we're looking at thinking about how we can help grow our economies globally, nationally, and locally, take pressure off our health and social care systems, and that's supporting our staff and resources, creating healthier and happier populations, which is about improving people's health and well-being, restore the balance to the environment, create equal and safe opportunities, and support the most valuable, vulnerable people in our society. These are the WIS goals. And I just want to make a big shout out to the global goals for sustainable development that the UN, all 190 countries agreed to, which I think is an incredibly important thing. Every single country in the world, every city in the world is worried about where the future is going to be because of the challenges that we're facing. And so a number of cities have been identified in areas, 25 cities and 5 communities, that are being fast-tracked to think about how we can develop cities that will support the ongoing communities that are within them. And the key to all this is helping individuals to connect with each other in the way that we've just done, and how the organisers today brought 5 people together that we wouldn't actually meet. We can do this at a city level, we can do this at a community level, and when we do it at the individual level, supporting each other, it's amazing how we can improve outcomes for all.
So on that note, also, I want to say something that is going on huge in India. There is a state of Andhra Pradesh, which is now building a huge capital that is involving all this environment, economy, and it's 34,000 acres is being taken over, and a huge ecosystem of change with a new capital called Amaravati. If you can Google it, AMARAVATHI, is being built on that concept, and is being built with visionary leadership, and an ecosystem that is going to change the way in which Indian life has to change. And in, I think, 5 to 10 years, that's going to be the next mecca of healthcare delivery. I think Dr. Tan might know about it, because there is a huge thing that the government of Andhra Pradesh in India is partnering with the Singapore government on that. And also, coming back to the totally different issue about how we in healthcare need to really focus on can we blame a patient? That's the next thing. You know, most of what I see is, you know, we say, oh, patient is not taking personal responsibility, or there is entitlement in healthcare. You know, is that the right way to do? That's my question to the panelists. Can we blame them for that?
Oh my goodness, no. And you know, it's I see so many people get frustrated with their patient for poor compliance, and you realize that the cost of good food in stores is more expensive than the cost of bad food, and they have a salary that doesn't allow them to have access, or they grew up in a situation where they don't have the information. Yeah. And you know, sometimes when we are stressed, let's be honest and say, what do we eat? We go straight for something that satisfies our need to get the energy we need to finish our day. And I just look at my colleagues and their eating practice during the day, and I said, you realize you're giving this advice to patients and you're not following it yourself. Yeah. But we cannot blame the patient. We just need to create the kind of situations where they can do the right thing easily. And the average advice I hear from patients, complaint I hear from patients today is they're confused. They're like, you know, this article said this is okay, but then this article said it's not okay. So what am I supposed to eat, or how am I supposed to live right now? And we haven't sorted any of those things out. So how can we start, you know, blaming people for what they do? And last but not least is we are so bad at explaining things to the people. I saw someone who had, you know, high blood pressure, 220, which is incredibly high number. Everyone's worried about him not taking his medication. And I said, has anyone explained to you what high blood pressure is? And he says, I don't know. I said, well, what do you do for a living? He says, I'm an engineer. And I said, your heart is like an engine that has to pump volume into every part of your body in pipes. Pressure is the size of the pipe. The higher the pressure, the smaller the pipe. You know the formula of what that means. And he's like, oh my God, why didn't anyone tell me this? And so we need to find ways to make people understand some of those invisible diseases that they don't feel immediately bad about, and how that impacts them in the long term, and start being consistent so that the information that they're seeing from everyone is simple, actionable, and easy to implement, because the environment was created to make it easy for people to walk to work or bike to work or whatever else we're recommending.
Yeah, I mean, like that is an amazing take on this. That's what I see. I mean, like, I did not personally realize myself and my own health. It took me 20 years of being a doctor, going the way we went for me. And then things happened to me, so that I realized and I changed myself. So, which is that is what drives me in trying to understand a person when the person sits in front of me as a patient, and I try to understand that person. But in this whole care of global healthcare topic that we're talking about, we have to look at not siloing healthcare. We are building beautiful sick care systems that really help when they get sick, but we ought to provide that high touch solution to the patients. Now, how do we do it? Is somewhere somebody has to start, and I guess Brennan did that.
So I think one of the things that healthcare systems seem to do, especially those who are at the top, who are trying to organize them, is spend more time reorganizing the actual system. And we spend huge amounts of time and money and resources teaching everybody about the new name to the organization or whatever it might be. I don't know how many multiple different changes the NHS has gone through. But one of the things I would love us to try and do collectively, and try and bring everyone with us, is perhaps try and not spend so much time reorganizing organizations, and spend more time improving health literacy within communities and amongst people, focusing on the needs of those people and their understanding of things, and helping to try and reduce some of the health inequalities by this relentless focus on quality, safety, as well. Ravi, you were talking about the need for clean toilets, and there's no doubt that improving health outcomes, clean water is essential. So in certain parts of the world, that may well be the focus on what it is, whereas in other parts of the world, it might well be about building this relationship between the doctor or nurse. It's going to be very, very difficult. I don't think there is a one size that fits all. But what we do need to do is value our clinicians, doctors, nurses, pharmacists, and so on, the managers who actually deliver. We haven't really talked about managers, but they're really important because they're the ones who deliver the service. Patients and carers, most of the care is delivered in the home. It's not delivered in organizations if it's going to be cost effective. And we've got to make the jobs for each of these people, managers, clinicians, patients, and carers, easier, make it enjoyable, make them feel happier, make them feel safer. And to do that, we're going to need to foster better relations between each other. The good news, though, is in the way that we've connected with each other, social media and the internet has an incredible, powerful way of being able to reach out to people in ways that we just could not do before. And it's thinking about not trying to organize this. I actually think it's going to be messy. It's going to be disorganizing. There's going to be conflicting views because different healthcare systems have different views on these things. As Brennan, you started, in the UK, it's tax-based. In America, they can't imagine a tax-based system. So there's going to be differences. We're going to have to break rules in the book. We're going to have to try and create new leaders, new managers, new followers as well, who don't just follow that traditional model of care, but start to think about these new ways of working that supports not just the most impoverished in society, but also the kings and queens of business, the multi-billionaires and things. And what we've learned is that you can do this, even though the needs might be slightly different.
Well said.
Well, and my hope is that we don't have to necessarily, there was a talk that Dr. Topol did, and he said the current crop doesn't get it, out with them, let's bring a new one. And I think that everyone right now, if you talk to them, is deeply frustrated with, trying really hard and not achieving. And so I find better coalition with decision makers and managers by not calling them stupid bureaucrats, but by actually trying to understand their perspective. Sometimes they don't know any better. A lot of them get transformed for personal illness, and they're like, wow, I didn't realize. But we need to start giving an opportunity for everyone who's currently in the system to evolve. And in Canada, we've had this big movement on First Nations reconciliation. I used to work at the Jewish General, where I met people who survived the Holocaust, and these extreme examples. But if you actually had to say, like, how did change occur, is by people saying, let's agree on the issues of the past, but let's stop now and declare that we're jointly willing to work towards a better solution going forwards. Because if you don't give people a chance to save face and abandon their old ways, they're just going to persist in their old way. And I think that fundamentally, some of them don't know any better, and some of them already know, but they don't know how to come out of their current constraints. And so we need to figure out a graceful transition model.
I do agree. And I think it comes down to what seems to be the common thread here is information and knowledge and acting on that. And I posted one link here. It was a determinants of health poster, and I have it right here, and I look at it every single day. I look at 38%, right? I think about 40% now is of your health is actually determined by your behaviors, your decisions, like your personal choices, the choice you make to do this or that. And that leads down another decision tree, either good or bad, and your social circumstances, your genetics, and your physical environment. And only 11% of your determinants of health is actually medical care. So I've heard that stat of 99% of your health is actually happens outside of the...
But Brennan, it's not just your personal choices, right? It's like this way the city builds your city infrastructure impacts whether you can exercise or not. The way your employer has created your working hours or the culture of your domain. The way your friends and family eat or drink. I mean, the difficulty I have with patients who are alcoholic, who are pressured within work environments to sit down with a glass of wine. That we've put the emphasis too much on the person, because then it's easy to blame them and excuse us as a society, as decision makers, as actors within it. And I think we need to start breaking these down further and saying, you're making choices within a range, but that range is given to you through some of these other means, and we need to act on all of them.
Completely agree. And I will say my city is not set up for exercise at all. You have to get in a vehicle and drive anywhere you want to go. And when I travel to another city and you can walk, a couple miles here and there just around town, I see how much more healthier you can be in a better environment. And there's a lot of things that need to happen for cities. And I think I think a lot of cities are starting to realize that. And you're starting to see a lot more bike paths, a lot more walking trails. And yes, I have a different perspective here. We're down in South United States where everything is scattered out. And the emphasis on healthcare just is not even in the conversation.
I mean, I want to do this thing. Just drew it right now. I mean, like this is what I try to tell my patients. Like, oh, what happened?
We can see it.
Okay. Basically, the base is the genetics, and each side is the environment. One side is other side is lifestyle. And all these have to fall in place to get a disease. But I used to believe that, but I used to believe you can use lifestyle and environment and help change your genetic expression. And I think that is what is something we have to stress. We can change our genetic expression, and that's what I think I have done for myself. And that's what drives me, because until 3-4 years ago, I never thought that I can change my genetic expression. So once you change your lifestyle and your environment, you influence the genetic expression by right food. Your epigenetic factors change the way in which you can express your genes. And then that's what we have to communicate with our family and our systems. We can take care of that. So thank you.
Absolutely, absolutely.
All right, Dr. Ernie, would you like to, I guess we can wrap this up now, kind of sum up everything we have going on. And everybody, I do think we should have a part 2 and part 3 of this. if you want to have some one-on-one podcasts, because I really want to dig down deep into some of these really interesting comments. So Dr. Ernie, would you like to sum this up?
Yeah, thanks, Brendan. In case I have to escape for a second, my dogs just entered the room, so if they start barking, I may need to take a time out. Anyway, I just want to thank everybody for getting on this webinar. It's excellent presentations and perspectives, and you guys are really stars in your own right, and your countries, not only in your countries, but nationally and internationally. Just getting back to some comments regarding lifestyle and environment, in America, we get inundated with fast food restaurant commercials during sporting events and other popular TV programs. And I'm not going to mention any names, but these are clearly not healthy foods for us. As we all know, obesity is pandemic, and it's affecting a good portion of the globe. And so this is certainly not helping us, the exercise portion. And as Dr. Ben Carson, who I referenced earlier, the famous pediatric neurosurgeon from Hopkins, said at our meeting in Washington the other month, is people have to have skin in the game. Whether it's their own personal well-being and how they take care of themselves, or even going to the doctor. Even if you have Medicaid or a government program, you should have skin in the game. Whether you pay $5 or $50 for your visit, everybody has to have skin in the game, and that helps responsibility. And I'm just going to throw a slide up here, and I'm going to share my screen. Just bear with me here. I'm technically challenged, but hold on one second. Let's see here. Can everybody see that? Can everybody see that? I know you're all muted. I'm asking you to respond.
Yes, I see it.
So this is let me get this out of here. I have a private insurance in Las Vegas, and I was asked to renew in April. And I'm not going to mention the name of the company. It really doesn't matter to this audience. But this was my current product up here, a so-called PPO. This is an alternative, and these are sort of like affordable care or the so-called Obamacare products. Now, we have a pretty educated audience here on this panel, and those attendees who are watching this. And I think we all did good in math. And if you can tell me, and I have a family of 4, my wife and 2 kids are teenagers. If you can tell me which plan I should pick, I will nominate you for the Nobel Peace Prize or whatever prize is closest to that goes along with healthcare. This is the kind of crap, excuse my French, this is the kind of crap that we deal with in America. And this is most of the reason that everybody is just up in arms with our current healthcare delivery system. So let me just minimize this slide, if you will. And I'm just going to, let me bring another, I'm just going to bring another one in here. One second. Okay, can everybody see that? So this is the problem. This is the problem we have. There's so many conflicts in America. We have the hospital association, we have the big insurance companies, and now there's maybe only 4 or 5, who basically, they're traded on Wall Street. They have Congress bought and paid for, and they make the rules. He who has the gold rules. So we're really in a logjam here. These are the folks that Congress that vote on this Affordable Care Act. They're tied in. They're bought off. These Congress may even have stock ownership in the hospitals or the insurance companies. And if you notice at the bottom here, physicians now have to be fully transparent to something called the Sunshine Act. When we give medical talks, you may have to too in your countries. You have to give any financial disclosures. And C, we can't talk to each other about how we conduct our business or what we charge. It's called the Sherman Act. And then we have this other crazy issue, which are networks. Now, to me, networks is good for when you have a cellular phone service, but we have doctors that you can see, you can't see, hospitals that you can go to, can't go to, pharmacies now, drugs that are all these little tier levels. And now we have the urgent care and emergency room issues. We have these freestanding emergency rooms, and you may show up there and they may not be in your so-called network. And next thing you know, you may have insurance, but it's not covered and you have to pay double what you would normally have to pay if you showed up at an in-network facility. And now they're calling it, it's a general catch-all term called surprise billing. I mean, there is such restraint of trade in America. It's not good. I'm not going to get into this, but this is the McCarran-Ferguson Act, which basically gives the healthcare insurance companies freedom from antitrust. They're actually allowed to talk to each other and discuss what kind of rates they're going to charge the American public, which is totally, boggles my mind. And Congress has been trying to fight it, but of course, most of Congress is paid off. So I'm just going to unshare my screen here for a second. Let me get back on here. Brennan, how do I get back over here?
Down at the bottom, it says stop share. That's what you're trying to do. And down at the very bottom of the screen.
Okay. So, I mean, that's just some of the points here. It's just basically the big corporations, the big money owns and runs the system here, and they basically have their way with us. We talked about direct primary care earlier. I believe you should just, the same way that you go shopping and you go to the store, that's how you should pay your doctor. And you should just have insurance for catastrophic stuff. God forbid, if you get hit by a truck or get the worst cancer in the world, it may cost you several $100,000. But otherwise, probably cheaper, more economical just to pay as you go. Just like any other commodity. And like that, when you have skin in the game, you may take care of yourself a little better. But this current system just doesn't want to make people get healthier because I know somebody's always there.
Mm-hmm. And I want to throw something out there too, because a lot of people worry about getting hit by a car, hit by a truck. If you actually think about your health or your vehicle insurance, I mean, I'm covered up to $1 million medical expense. So everybody's worried about getting run over by a vehicle, but if you're in your vehicle and it's a requirement that everybody has vehicle auto insurance, that's a worry that I don't think a lot of people understand, that it's already paid for with your vehicle insurance. That's a different conversation though. So yeah.
I think that the interesting thing is that having talked to now many people across different areas, the billing model doesn't seem to matter that much. And Dr. Atulga, one day after he wrote his checklist book, was visiting Vancouver and we had a chance to speak, and I said, where have they figured it out? The World Health Organization sent you as a surgeon to see the best places for surgery, and where is that mythical land? And he said, he thought about it for a minute and he said, there's more similarities between centers of excellence across countries than with that center and the hospital 100 kilometers away in the same place. And so I think that, what frustrates me is the average patient doesn't understand that by the time they decide that, like, oh, I should go see a doctor, it's probably too late. And there's been a number of things in place that Dr. Ravi mentioned around genetic expression that's been lasting for a long time, that if we could just implement, that would be better. And so in Canada, I get question often of like, why don't you run for Minister of Health? And what would you do if you're Minister of Health? And so I've had a chance to ponder this one before, but my number one thing I would do is I would actually make gyms free the way libraries most places are, because people can't exercise outdoors, whether it's too cold or too hot, or they don't think, it's boring to walk on the street by yourself. And so I would make that change immediately in every country that is possible to make that change. I would make foods, healthier foods to be on par with the price of food that is not healthy. And I mean, there's a number of these changes that I would make that have nothing to do with direct healthcare, but to me are all about enabling the determinants of health.
Yeah, I want to add something on that skin in the game thing. Yes, I would love to have people understand their health and then get the skin in the game. See, the problem is we are not aeroplanes. We are human machines, which is very unique. All the six of us talking in this webinar are uniquely different. And how is a common person who is a plumber take that unique understanding? And you cannot throw him and a doctor who has been a doctor for 20 years and realizes that he has a problem, and then now you're telling the plumber to do the same thing. I don't know anything about plumbing, and I would expect that the plumber would not know it. So the skin in the game is great, but then we need to, when we're telling them to have a skin in the game, we need to give them the tools and provide that high-touch solution before we tell them to have a skin in the game. Please tell the ex-presidential candidate that.
No, I totally agree with you, but I think I'm talking more for people who are the government assistants or the Medicaid type programs that feel like they can just see the doctor whenever they want and they don't have to take care of themselves, like you said. And at some point, whether it's $1 or $50, it just helps. It helps the relationship and it keeps people on the same page. They have to just. And you can help them. That's our responsibility. Our responsibility is to educate them. And we're not. It's not. I'm not. I didn't come. If I came across as a punishment, punishment model.
No, you did.
But
you did.
Big brother can't be there.
Yeah, you did great. I just want to make sure that in this context of discussion, the communication. This is the first point of my 5 things of problems of healthcare. Communication, personalization, realization, implementation, and reevaluation. If we take the cost out of the factor, these are the 5 things. Once we help them and understand themselves, then fix all these other things. And that's what amazingly US healthcare can do, amazingly any healthcare system can do. And it's just that knowledge and taking ownership of the problem. And I myself have determined that I'm taking ownership of healthcare problem. I don't know, I'm crazy enough to do that. But we are here all together this Saturday morning talking about this. So every one of us is crazy enough about that, I guess.
I think one of the things I've learned is that all people, whatever their backgrounds, all have certain desires. Someone's mentioned Maslow's triangle before, about the need for food, shelter, clothing. And once you have that in place, then you can start to think about other things as well that you can do. I agree with Ernie that if you give it for free, people won't value it. And one of the things about the NHS is that it's been free at the point of care, but many people are now starting to ask the question, is it sustainable into the future? Or are we going to have to start thinking about some sort of payment model that enables us to go beyond just the basics, because the cost of healthcare is rising at such a phenomenal pace. My own feeling is that there's more than enough money in the system to pay for it, and it doesn't have to be so expensive. But what we do need to do is we need to value each other and the contributions that we make. Interestingly, I might have spent 18 years learning about diabetes, but actually I don't know what it feels like to live with diabetes. The average diabetic patient only spends about 3 hours in front of a healthcare professional. The other 5,787 hours, they're at home alone with their diabetes. So I would argue that the knowledge that I lack, the experience I lack, is how to live with diabetes. And that's why there's a really interesting dynamic. Whenever I do presentations at conferences and things, I always insist on bringing a patient along with me, because healthcare is a team sport. Health on its own is your own thing, but healthcare is a team sport. And I can talk about it from the medical perspective, but the patient describes what they're doing in their 5,787 hours when they're not in front of the doctor or the nurse. And when we start to think like that, we begin to realize how we've got to involve everybody. and try and make it as easy as possible for people to access information and get that knowledge. Nelson Mandela talked about education is the most powerful weapon which you can use to change the world. And if we can try and take that education out to the world and try and reduce some of the difficulties that people have, then maybe we might be able to help to make it better for all.
I agree. Well, everyone, I think we had an excellent discussion, and this was very exciting. And like I said, I think it's a world's first. And I hope we can reconvene anybody that wants to do a podcast later, just individual, and really hit on some details. But for today, if anybody else has anything to add, let's go ahead and talk about it. Or if not, we can go ahead and end this for the sake of time so we can get on with our day. So I'll open it up for any closing comments. If not, I will stop recording. All right, everyone.
I just want to say thank you to everyone for being part of this, the panelists as well as the organizers. It's been great fun, and good luck. I look forward to the next podcast or next meeting together. It'd be great. And if we can all connect with each other and continue the conversation beyond this, then that'd be fantastic.
Yeah, please share the common email thread, Brennan, or if we can do that, and it would be great. Because,
Brennan, how many people participated as participants?
We had a total of, I think, about 15 people. So a lot of times when we have these, we start sharing them around on social media. We'll put it on YouTube, and then we'll post it on Facebook, Twitter, LinkedIn, and we'll get a lot of good feedback. So it's kind of like a downstream thing. Well,
and that's key, because no one made us do this. No one made us, and it's that sort of going back to the initial quote of concerned citizens. And we need to have the dialogues and exchange ideas. And I love the fact that we didn't all agree on everything, because then it would be boring. But it's in this conversation that starts insights that I'm sure will participate. And I thank everyone who shared links on the chat and asked questions from the participants, because without them, this wouldn't be the same.
I agree. And I'm a big proponent of the open source movement, where our ideas can build off other people's ideas, freely share what works, what doesn't, so we can all excel as a species, because we've got too much fights between countries, in countries, but we're all spinning around this rock together. So I think we should work together. So I'll sum up this webinar here. I'll put it on our website with the video and with a transcript of all the messages that happened over there, and I'll share it with y'all. That'll probably be Monday. And then feel free to share it on your social media channels, and then let's just keep the conversation going.
Thank you. What is that before you hang up, what is the scientist.org? What is that you had there?
Sentient.
Sentient.
Let's see, where's that?
It's an open source machine learning platform.
Thank you.
Yeah.
Thank you, guys. Take care.
I'm going to stop recording if anybody wants to.
Okay.
Yeah.
Bye.
All right.
Bye.